Hello students, so our next topic in GI series or gastroenterology series or small intestine disease is celiac disease. So we are going to cover celiac disease. So let's discuss in very fast lecture. Try to be very fast. So what is a celiac disease? It's an autoimmune disorder characterized by intestinal hypersensitivity. So hypersensitivity, first thing is patient is sensitive to something, the next thing is hypersensitive to something, and there should be something. This something is gluten. I never remembered it as hypersensitive to gluten. I remembered it as hypersensitive to gliadin, which is present in gluten. So, autoimmune disorder characterized by intestinal hypersensitivity to gluten, a grain protein. So, a grain protein. If you consume grain products, you know those products which are made up of wheat you mostly contains gluten, and whenever you go to shopping, you purchase a wheat bag, there is written on some products gluten free diet. So this is the gluten, and such patients, some patients are having celiac disease, so they are hypersensitive to gluten. So what are the synonyms? We can call it as celiac sprue or gluten G sensitive enteropathy GSE. So what is the epidemiology? We are going to discuss about the epidemiology. So in USA, epidemiology, usually females are more prone to have celiac disease than males. So next thing is age of onset, in which age celiac disease develops. So the thing is that you already know when a baby born, he in first 6 months, usually he is mother breastfed or he is given fluids like uh, milk, water, etc. After 6 months, he is shifted to solid diet. The solid diet can contain wheat. So patient comes to you with after 6 months or after 7 months, like patient of 10 months of age comes to you to have diarrheal features. So you ask his mother whether she is having diarrhea from 1 month or 2 months, and when you start giving him solid food, and what are you giving him in his solid diet. So you ask about the history is very important in such patient. So first age of onset is when patient is of 8 to 12 months old, or 2 to 3 months after exposure to solid diet or wheat based diet or gluten based diet. So in US, every 150th person is patient of celiac disease. So uh, I was telling you at 8 to 12 months, the age of onset is 8 to 12 months, or the next, it's a bimodal incidental disease. First stage is 8 to 12 months. The next age patient can have celiac disease is 30 to 40 years of life. Of age patient can also have celiac disease. So what is the etiology? Causes. There is hypersensitivity, autoimmune, you getting something, genetic predisposition, and it got a strong association to HLA antigens. You have to remember HLA, DQ2 and DQ8. Like 8 is easy to remember as patient usually presents with of 8 to 12 months of life, HLA, DQ2 and HLA DQ8. So if a patient is consuming, the risk factor is also the second cause is consumption of gliadin or gluten diet. Gliadin is present in wheat, rye, barley. Spelling are So what will happen? Consumption of these products leads to an autoimmune reaction within the small intestinal wall. So what is the pathophysiology? What will happen when you consume such products? Draw automatic shapes. So pathophysiology. So you have to understand me very clearly. Symptoms manifest when a patient consumes gliadin. A patient comes to you after consumes gliadin. So what will happen? There is an immunological response to gliadin. This gliadin is a product of gluten. So gluten is present in wheat, rye, barley. So when you consume gliadin products, what will happen? There is an immunological response. There is production of tissue transglutaminase. So this tissue transglutaminase is released. So this tissue transglutaminase is released. This modifies gliadin, and what will happen? There is T cell reaction. This T cell reaction is activated by this modified gliadin. So in your body there is a T cell reaction which is due to modified gliadin by consumption of gluten diet. Gluten should so you consume gluten. What will happen? Your body produces tissue transglutaminase, and this tissue transglutaminase modifies gliadin from gluten proteins. This gliadin leads to T cell reaction. T cell reaction, and this in this T cell reaction, T cell reacts to gliadin. So what will happen? There will epithelial damage. This epithelial damage leads to villus atrophy, crypt hyperplasia, loss of brush border. So when there is loss of brush border, when there is villus atrophy and hyper chronic hyperplasia, yeah, crypt hyperplasia, when there is crypt hyperplasia, when these three features are present, there will be malabsorption symptoms. As we already discussed, that secondary cause of lactose intolerance is celiac disease or any autoimmune disorder which can lead to mucosal damage. So epithelial damage in celiac disease leads to villus atrophy, crypt hyperplasia, and loss of brush border enzymes. This leads to impaired absorption, in small intestine, especially distal duodenum and proximal jejunum. So what will happen? Patient presents to you with uh, abnormal absorption symptoms or malabsorption symptoms. So we are going to discuss about clinical features. How a celiac disease patient presents. Clinical features. You understand the pathophysiology. A patient consumes gluten or gliadin containing diet. What will happen? Body produces tissue transglutaminase. This tissue transglutaminase modifies gliadin. This modifies gliadin activates T cell reaction or T cells. These T cells react with gliadin and leads to epithelial damage. This epithelial damage leads to villus atrophy, crypt hyperplasia, and loss of brush border. This loss of brush border leads to uh, no release of brush border enzyme. There will be a malabsorption symptoms. How patient presents clinically. So patient comes to you with chronic or recurring diarrhea. What kind of diarrhea will be? There will be steatorrhea, fat in diarrhea. In simple way, foul smelling. So what is the features of fatty diarrhea? Foul smelling, bulky, oily, floating stools due to increase in stool fat content. I already discussed in diarrhea that if a diarrhea is fatty nature or steatorrhea, what is the definition of steatorrhea? Foul, bulky, floating on water surface, foul smelling, bulky, oily in nature due to increase in stool fat content. So patient is having diarrhea of steatoric nature. So next clinical feature is abdominal bloating, flatulence and pain. And the third clinical feature, nausea and vomiting. Nausea and vomiting. So patient lack of appetite. Rarely patient presents with constipation. Rarely. So you can skip it. So these are the intestinal symptoms of intestinal manifestation of celiac disease. So what extra intestinal symptoms? Extra intestinal symptoms develop in a patient of celiac disease. So why extra intestinal? As you already know, patient having malabsorption syndrome, these deficiency of different compounds leads to other systems affected. Like malabsorption symptoms include fatigue, malabsorption symptoms, fatigue. Patient will have weight loss due to diarrhea, vitamin deficiency, iron deficiency, anemia, osteoporosis, hypocalcemia directly causing osteoporosis, hypocalcemia. In children, what will happen? A a child consumes solid products and he is a diarrhea patient. What will he gain? He will gain nothing. In a children, he will not grow. Failure to thrive, growth failure. His puberty will be delayed. What other feature? Secondary hyperparathyroidism. Skin changes happen to celiac disease patient. Dermatic changes. These are dermatitis herpetiformis. Neuropsychiatric symptoms will also develop. Neuropsychiatric symptoms like peripheral neuropathies, numbness, burning sensation, and tingling of hand and feet. Moreover, headache, ataxia, depression, irritability. These are all extraintestinal manifestation of celiac disease. So, what are the gynecological manifestation or association? Reduced fertility, or such patient can also be infertile. So, what endocrinal changes take place in celiac disease? There will be autoimmune thyroid disease. There is already an autoimmune disease running. So next one is autoimmune thyroid disease type 1 diabetes mellitus. So there is an association with syndromes. If a Down syndrome patient comes to you with diarrhea, what should you suspect? You should suspect celiac disease. It also associated with Turner syndrome and Down syndromes. So what other conditions, like it is an autoimmune disease, other autoimmune disease are also associated with it, like autoimmune hepatitis. The next thing is IBS patient can also have associated celiac disease, IBD, rheumatoid arthritis and other autoimmune disease, sarcoidosis. There is strong association with all these diseases. Selective IgA deficiency, atrophic glossitis. These are all diseases associated with celiac disease. Associated, let's diseases. So how will we diagnose? The first thing is that we'll go for serology. Diagnosis. So first diagnosis based on initial testing is serology and esophagogastroduodenoscopy. And what will we do? We'll take duodenal biopsy to confirm whether there is villus atrophy, crypt hyperplasia, or brush loss of brush borders or not. So these are the initial testings. So what will happen? A patient who is not taking gluten, he will have negative serology test, and if a patient consumes gluten, he will have positive test. So what will we do? We will do HLA based testing, or we can do gluten challenge. So next our laboratory studies will be, these are routine studies. We will go for IgA, tissue transglutaminase antibody, tissue TG, let's be very accurate, TG IgA test. This is the initial test and crucial part of celiac disease serology. We are discussing about serology of IgA, tissue transglutaminase antibody, like tissue transglutaminase antibody. So very highly specific test. So next thing is we are going to test highly specific total IgA level. Why we are performing this IgA level? Because a celiac disease patient is having high prevalence of IgA deficiency. If a patient is having low IgA levels, we will perform further serology tests like IgG based serology test. So what additional studies is required? We will go for IgG testing. What we are going to check? We are going to check deamidated gliadin peptide. We are going to check for checking deamidated gliadin peptide. We are going to perform IgG based testing. In those patients having IgA deficiency, we are going to perform IgG based testing. And what we are going to study? We are going to study tissue transglutaminase antibody TG IgG. So next thing we are going to study IgG deamidated gliadin peptide DGP deamidated gliadin peptide IgG. You are going to perform these tests if there is IgA less in quantity. So next thing is HLA typing testing. This is a second line test. Second line test. What we are going to check? We are going to check HLA DQ2 and DQ8. So next antibody we are going to test is anti-endomysial antibody. This is a second line confirmation testing, highly specific. So we already discussed that we are going to perform the serology as well as EGD, esophagogastroduodenoscopy with biopsy, duodenal biopsy. So we perform endoscopy with biopsy. This is a confirmation test. So all the positive serology patients, we are going to perform endoscopy with biopsy. So if a patient comes to you with negative serology but high clinical suspicion of development of celiac disease, we perform endoscopy with biopsy. At least five duodenal samples are taken in celiac disease. From one or more than are taken from duodenal bulb. So what will happen? We'll find histological findings. What are the findings we are going to find in our biopsy is crypt hyperplasia, villus atrophy, and what will happen? There will be intraepithelial lymphocytic infiltration. On our biopsy, these are our will be our findings. So with advancement, there is video capsule endoscopy. You can also perform it video capsule endoscopy, available in developed countries. I don't know about it in Pakistan is available or not. So for further evaluation, what will you do? You can have gluten challenge, you can have nutrient deficiency screening, so you can test for malabsorption, and uh, and you can follow up. In follow up, you will repeat battery studies after 3 to 6 months or 12 months, then annually. So what is the treatment? Very important step in our video lecture is treatment as a medicine student. First thing, you are taking gluten. Your patient is consuming gluten, and gluten is causing hypersensitivity or uh, producing defect or producing damage to your body. You will start to counsel and advise him to strictly lifelong gluten free diet. Live a gluten free diet. Keep yourself away from those products which contains wheat, rye, barley. So if a patient is strictly on gluten free diet, his symptoms improve. So what will we give? Recommended diet: rice, corn, potatoes, soya bean, so many options available. So if a patient in our lactose intolerance video, we discussed that there is a secondary cause. Any autoimmune disease can also lead to, or acquired disease can also cause lactose deficiency. So in celiac disease, there is brush border loss. So patient is having lactase deficiency. We will advise him not to take lac lactose or avoid milk products. So what will we give? We give patient iron plus vitamins. If there is any iron deficiency or vitamins deficiency, we will cure patient's malabsorption symptoms. So what kind of complications can arise? So in I have studied about a drug which can be given in celiac disease, Dapsone. We can give it in dermatitis herpetiformis. If a patient develops celiac disease and develops dermatitis herpetiformis, we can give Dapsone to such patients. So what kind of complications can arise in such patients? First thing is malabsorption symptoms can develop, like iron deficiency, anemia, folic acid deficiency. There can be vitamins deficiency, peripheral neuropathies can develop. So malabsorption symptoms can develop. Second complication is secondary. If you want to take eat kurkures, you can join me. Secondary lactase deficiency. This celiac disease enteropathic associated increases risk of enteropathic associated T cell lymphomas. So a patient can also have refractory celiac disease. Like you you told the patient that he is having celiac disease, he has to be on a gluten free diet. So he did not take gluten diet for 12 months. Still he is having symptoms of celiac disease which are worsening. This condition is called refractory celiac disease. Very important point for USMLE and PLAB students. So this condition manifests with, like, any possible cause can be lead to celiac disease. Like patient is not on totally gluten free diet. Maybe he is initial improvement followed by relapse despite maintaining gluten free diet, or maybe there is any only partial improvement despite gluten free diet. So in this condition, patient may develop ulcerative gingivitis. So we have to take, in severe cases we have to treat with steroids. So this is the complications of celiac disease. That's all about celiac disease. If you have any question, you can ask.